Yes, ma'am, we are live. We can begin.
Good afternoon, dear friends. Um, this afternoon, the topic in front of us is adolescent PCOS. First of all, my thanks to Dr. Prakash Trivedi and his team from ISAR for having invited me to be part of this very useful venture that they're doing, and for Dr. Moon and Zydus for making it happen. So the topic in front of us is adolescent PCOS and why adolescent PCOS. PCOS, we know, is one of the most common endocrine disorders in women, more common than anything else. And PCOS does affect anywhere from 5 to 10% of the female population worldwide, immaterial of what ethnic background they are in. But then adolescent PCOS, why should we focus on only the adolescent PCOS? Why is it an important time frame for a woman with a PCOS? Why diagnosing PCOS in adolescence is important, and how and why is it different from the adult PCOS? How can these young women, in what ways can they present to you? How do you then proceed for further diagnosis? And then how do you manage them? Do you manage them just the way you do an adult, or is it anything different? And for what reason is it different? These are the questions we'll be addressing today. So we'll start with what PCOS is. PCOS is of dual origin. There is a genetic component and there is an epigenetic component. Both are important, but it's not a single gene as you are used to thinking about a genetic disorder. There are multiple genes involved, and over many decades, in spite of a lot of research, we haven't honed in on one genes. But generally, the majority of the genes which are implicated are genes which control the reproductive system. It may be anything from GnRH to LH to FSH to testosterone or any of the gonadal and non-gonadal hormones. The genes are the genes which control this hormone production and their receptors as well. This varies from woman to woman. It can be one gene or several genes which they have inherited and which will be responsible for their problem. So from patient to patient, you find so much of difference because of the fact that it's polygenic and the genes that are involved are different in different individuals. And more than that, there's a strong epigenetic component as well. Epigenetic component is everything in the environment and everything around what the individual is, which can have an effect on the genes and produce a change in how the gene works. Basically, it can work in utero when the female child is in the mother's uterus. In terms of the mother's hormonal component, a mother who's got an active PCO and has manifestations of it with high testosterone component that can go into the uterus and affect these genes as well. At birth, a baby which is very small or very big, in other words, low birth weight babies as well as the large birth weight babies have an implication, because the very small birth weight babies or the growth retarded babies, according to the Barker's hypothesis, these babies put on weight very rapidly and they end up having a lot of metabolic problems later in life. The large babies, the very large GDM kind of babies, also run into problems with their metabolic change later in life. But then the most important part of what this young child has inherited is at adolescent, because that is the time in life where things change within them and things change around them as well. That is the age where there are a lot of surrounding things change, which have a lot of impact on them. At the same time, they change as individuals as well. And we've got to first of all see why this adolescent period is important for them. So we talked about the intrauterine environment, computer programming, how it can change it, at birth, the small foregates and large foregates, and childhood and adolescence is when you have manifestations of visceral obesity, premature adrenaline. Sometimes that can happen with the pubic hair comes before anything else, and even at the age of 7 or 8, the typical PCOS manifestations start as well. A little later, it's infertility, and much later in life, it's coronary vascular disease, endometrial cancers, and maybe even breast cancers. So the spectrum of problems that we see in life changes. But at adolescence, there is something very significant that happens to them. And this is a fairly recent concept, and this involves what are called kiss peptides. And what are these kiss peptides? When we did our physiology decades ago, we probably never heard about K-peptides, but K-peptides are essentially upstream regulators of GnRH neurons, and they are involved in various functions of reproduction. They are involved in brain sex differentiation. This is the phase where a child becomes an adult, the body becomes ready for it, the mind becomes ready for it, and all of those changes are controlled by the central nervous system. That's where it starts. So the brain sex differentiation happens around that time. And that is responsible for puberty onset, gonadotropin secretions which start changing around adolescence and puberty, and then ovulation happens subsequently, and production of oocyte happens subsequently, and metabolic regulation of fertility in terms of gonadal hormones also happens that way. So it is upstream from the pituitary. We are all aware of GnRH analogs and GnRH as such. Then FSH and LH and working on the gonads on the cumulus cells and the Tinker cells and producing the hormones. But this is upstream from the GnRH secreting area in the pituitary. It's upstream in hypothalamus. And these K-peptides have two effects. One is called the juvenile brake, which is holding the GnRH secretions of a certain kind in the brake up until a certain age in puberty. The change in the puberty happens, it's called the pubertal accelerator. So these are terms that we have to become familiar with. Things have been put in a brake up until a certain stage in an individual's life, in a woman's life, in a child's life. And at puberty, things start changing, and that's what happens. And K-peptide metabolism is now supposed to be the responsible agent for all of these things to be happening. So at puberty, the pathophysiology of PCOS, somebody who's already inherited the genes, starts happening with the awakening of the hypothalamic pituitary axis, which happens at puberty. And there are two main things happen with this awakening of the hypothalamic pituitary axis, which is the ratio of FSH stimulation and the LH stimulation changes, and the growth hormone is also starting to get secreted more. The growth hormone, when it starts getting secreted more, growth hormone is responsible for the growth spurt that happens around puberty. And then that is also responsible for increased insulin resistance in the periphery, as well as the muscle, bones, liver, and all of those essential organs as well. And this means that there is insulin resistance at the cell level, and growth hormone is responsible for it. And insulin, then there is a situation which causes hyperglycemia and hyperinsulinemia. And this hyperinsulinemia then creates a lot of negative effects which are responsible for PCOS. At puberty, the manifestations happen because the insulin levels go higher. And directly the LH levels also go up in FSH and LH. LH is the one whose action the ovary produces androgens. So androgens, there is an increase in production of androgens from the ovary. There's an increased production of insulin from the pancreas, and these two are then the reasons for all of the pathophysiology of PCOS. The pathophysiology, all the manifestations are based on two things. One is hyperandrogenism, the other one is hyperinsulinemia. So you think of what happens in puberty, you think about a central change that happens, which increases the growth hormone, which increases the luteinizing hormone, and ultimately increases the androgen production from the ovary and insulin production from the pancreas. So this hyperandrogenism is unique, and it's the intrinsic leading to abnormal steroidogenesis. So most of the pathophysiology that we see typically is because of these two things: abnormal androgens and abnormal insulin levels in that individual at that time. Ovarian hyperandrogenism, the source of these androgens is the ovary, not that in PCOS. It's ovarian hyperandrogenism is the major source of androgen excess, and it accounts for most of the major features of this syndrome. Insulin resistance, peripheral actions, as we said, the insulin receptors do not work as they should be. Increased growth hormone, glucose doesn't enter the cell, levels goes up. And these levels then subsequently rise to a lot of other problems, potentiating androgen as well as insulin. So how does it present to us? How do we see all of these changes which are happening deviate from the normal and produce too much insulin and too much androgens? what happens to this young female, and how does this problem present to us as physicians in our office? One of the common things that happens, cutaneous signs of hyperandrogenism, where they start, where there is a degree of hirsutism, which is socially concerning to this young girl as well as her parents. And there may be acne, which is treatment resistant. It's not the simple acne that happens around adolescence, maybe one or two lesions in the face. It's more difficult to treat acne. Those may be the presenting signs. So this young girl may be coming to you complaining of facial hair or abnormal amount of hair growth, or an abnormal amount of acne, which is not responding to the usual treatments which are given elsewhere. And the second problem that you see then is with menstrual disturbances. Again, the same problem, because of ovarian and secretion of hormones changes, and there is an increased androgen level. The normal ovulatory cycle, which sooner or later happens, but it becomes very delayed. And it could present with primary amenorrhea up until a certain age. It could present with irregular cycles or infrequent cycles up until a certain time in life. And secondary to this AUD, there can also be HMB or increased menstrual bleeding. When they have very delayed periods, suddenly one day when they start bleeding, they bleed either too much or for too long a period of time, and it doesn't stop. So menstrual disturbances can be primary amenorrhea, secondary amenorrhea. It can be irregular cycles, delayed cycles, or it can be increased as well. Anyway, they can present as well. And the third, and a very interesting way that present to you these days, is by a diagnosis of polycystic ovaries. It has become not uncommon today to see a young girl and her father, accompanied by her family, walking in, and you ask them what your problem is, and they may say polycystic ovary. And you go for a lot of education things to schools and colleges, and you see a lot of women getting up and saying, "But I have this." How do you know? I have been told. I have been told by a physician or a radiologist. They end up having an ultrasound for some reason or another. Some reason or another, which gets diagnosed by an ultrasound which are done unstable. Okay, but just stay. I'm sorry, the internet was just a little bit of trouble. But anyway, these polycystic ovaries are often picked up by a casual ultrasound, abdominal ultrasound done, even for some other reason, like abdominal pain or suspected appendicitis, and the sonologist or the radiologist gives a report saying that there is a polycystic and polycystic, and they have been told that something is wrong with ovaries. And you can imagine how much of distress it causes that girl who's facing her entire future to be told that something is wrong with her ovaries. It gives rise to more problems psychologically in the parents as well. And they come to you in desperation saying that I've went for something and I've now been told that there's something wrong with my ovaries. So that has become a not infrequent scenario these days. Another way these children come to you is with gross obesity, a lot of obesity as well. And sometimes it may be with evidence of insulin resistance because of the hyperinsulinemia. You get insulin resistance, evidence of insulin resistance, which may be a acanthosis, hidradenitis, or septoria, that kind of manifestation. So all these different scenarios may be the way these adolescents present to you with PCOS. When they come to you, then what is your next step? We just treat the symptoms. We know how to correct a cycle which is not okay. We know what to do with a youngster. We know what to do with the age of who's put on to jail. And we also know what to do with other symptoms that can be presented. So do we just start treating, or do we need to do something more? The answer is that we definitely need to do something more. That something more should be an actual diagnosis of PCOS. Diagnosis of PCOS is different from picking up one of its signs or symptoms because it has a lifelong implication. Hirsutism or irregular cycles without underlying PCOS is short-lived and it can be treated easily. That individual is certainly somebody who has PCOS. It has lifelong implications, This young child may have come back to you at a certain age with subfertility, and beyond that, it may be any kind of metabolic syndrome manifestation, and finally, even with endometrial carcinoma, earlier than usual in life or around perimenopausal age. So we have to think PCOS as a problem which has a lifelong implication, and I think it is our responsibility to make that diagnosis at that point in time and do the adequate counseling so these children can be looked after for a long time in their life. Now, why is diagnosing PCOS more difficult in the adolescent age group? That is because of the signs and symptoms that it manifests with. And let's look at what common pubertal changes are. Common pubertal changes, as we very well know, they do get some acne, which is common in adolescents. But hirsutism, even if you're prone to developing hirsutism, it's much longer time to develop. So they may not right away come to you with hirsutism also. And second thing, irregular cycles again are very common in adolescents. 85% of the cycles are anovulatory in the first year after menarche. 59% of the cycles are anovulatory even after the third year of menarche. So how do you take care of pathology or medication of PCO? And ultrasound findings again can be very inconsistent because a lot of adolescent ovaries are larger than usual, more number of follicles than usual because of the anovulation that happens. Now, all of these are normal and common pubertal changes. They are also the diagnostic criteria for PCOS. Hyperandrogenism, irregular cycles, ultrasound findings of the ovary are the three things that you need to make a diagnosis of PCOS in an adult. According to Rotterdam criteria, you have to have two out of the three to make a diagnosis of PCOS in an adult or an older woman. But however, in an adolescent and all these three things can happen anyway. What should be your criteria? The criteria for diagnosis of PCOS is different. All three Rotterdam criteria should be present, not just two or three. You should have an ovulation, but then this anovulation should be present for at least 2 years after menarche. Or if the child is present to you with the primary amenorrhea, the age group at which it becomes significant is 16 years. The hyperandrogenism should be biochemical evidence of hyperandrogenism rather than just phase. And ultrasound diagnosis, these two various sizes more important than the antral follicle number, and increasing stroma should also be noted and included in the diagnostic criteria. It was originally thought of as MCM, they increased to 8 size, but now they have increased it even up to 12 million, so it has to exceed 12 cc's for you to make a diagnosis. So, menstrual puberty, hypothalamic pituitary ovarian axis matures progressively over a period of several years after menarche. And primary amenorrhea, as we said, lack of menarche becomes significant only after 15 years of age or 3 years after the onset of breast development. So, a child gets a breast development and still does not 3 years after that becomes significant. Secondary amenorrhea, any cycle that's more than 30 days amenorrhea is secondary amenorrhea. That again is a significant finding. Oligomenorrhea are infrequent periods. In the first year after menarche, the cycle length should not exceed 90 days. In other words, there should be at least 4 periods in a year. Post-menarche year 2, average cycle length should be at least 60 days, which is at least 6 periods in a year. 3 to 5 years, 3 to 5 after menarche, average cycle length should be less than 45 days, and it should be at least 8 periods in a year. And post-menarchal years, 6 and over, the cycle length normal of anything over 40 days, or anything less than 9 periods in a year is considered as abnormal. So, clinical hyperandrogenism, how do we find that in this age group? Unwanted face and body hair or alopecia having negative psychosocial impact in the child or her parents is important. Terminal tests are important. More than film of length, variable shape of pigment, it should be there. It should not be just it should be type of hair should be different. And modified feminine, we all are aware of, are not related to right at the moment, are also right. So, when you come to hirsutism, half of mild hirsutism is only idiopathic. So you have to look at hirsutism, decide for yourself how severe is it. Only moderate to severe hirsutism is relevant, and clinical hyperandrogenism is a less reliable indicator than biochemical parameters in adolescents. So you have to go for the biochemical testing at this age group, and you cannot take only the clinical hyperandrogenism as a relevant indicator. Acne, it's got to be not mild acne, it's got to be moderate responsive to conventional management. Seborrhea can be taken as an indication. Virilization, however, is not finding temporal hair recession, increased muscle bulk, voice deepening, all of these things should be considered not as finding, because that is too much of androgens that cannot come from the ovary in non-pathological ovary. So that is something more than just PCOS. So when you say that you have to have biochemical, which biochemical and which androgen are you looking at? Which androgen is significant? Free testosterone is the most sensitive test possible, but however, free testosterone assays are cumbersome, costly, not really available, or if you can have it available even at an expense, that's probably the best thing for you to get. Total testosterone, however, though, is easier to perform and available, and 40 to 60 nanograms is considered a limit of normal. 100 over 150 nanogram PL requires evaluation in as a cause of hyperandrogenism. And but however, if the child is already put on hormonal contraception, these values, you will have to take them off hormonal contraception and recheck it after 3 months. 17 hydroxy progesterone, you don't have to do it everybody, but if clinical findings suggest genital adrenal hyperplasia, hypertonicity or not, then you have to do it. And that's a value, strongly suggests a diagnosis. DHEAS is to rule out adrenal cortical carcinoma or adrenal cortical androgen. It comes from the adrenals and a very high level indicates pathology in the adrenals, and we have to proceed further in that line. Cortisol measurements need to be done only when Cushing's is suspected based on either history or examination, the stride, the proximal muscle weakness, and the centrifugal obesity. Ultrasound should not be used for the diagnosis of PCOS in those with a gynecological age of less than 8 years after menarche, due to high incidence multifollicular ovaries in this stage of life. So ultrasound is the least important criteria, and it's a criteria which is absolutely not useful before 8 years. And even much later, you got to be very careful. It cannot be an isolated thing that you use. You have all 3 criteria. The least important of all 3 criteria is ultrasound. So none should ever be making a diagnosis of PCOS only based on an ultrasound in an adolescent. Definitely not pubertal, and not even at puberty or beyond puberty for the first few years, because PCO morphology is seen in 40% of young women 2 years after, 2 years after menarche, 35% at 3 years after menarche, and 33% 4 years after menarche. And also you have your technical limitations of doing a transabdominal, picking up the ovaries and counting the number of follicles in obese and overweight children, which the burial might be. So again, stressing that the diagnostic criteria for PCOS in adolescents, we have all the criteria. Hyperandrogenism is biologically confirmed. Menstrual irregularity is present for at least 2 years post-menarche, and polycystic ovaries increase, including both an increased size and increased number of follicles, and size being even more than the number of follicles. What about obesity? A lot of us have a tendency to have an obese child walk to our offices, and the parents more worried about the obesity than anything else, and they may even have been labeled as PCOS and therefore obese earlier. So is that the way to approach an obese child? PCOS is the most common obesity-related endocrine syndrome in a female. So you have to think of PCOS. However, PCOS in obesity is different from generalized obesity. It's usually a central android obesity, which means that apple shape is more abdominal fat, Waist circumference is a very useful, simple thing that we can do at the bedside. Over 88 in adolescence is significant. And body fat content is excessive for BMI. So even if it's a young child whose BMI is not so high, if she is putting on weight around 30 and the waist circumference is more, that's important. That's a body fat content. The distribution be not in the normal way should be an indication, can be considered as an indication for further work. And reported incidence of obesity in PCOS, though, is only 15 to 75%. So it is not a diagnostic factor for PCOS. So just because a child is obese, we cannot call that child PCOS. Not every obese child is definitely a PCOS, and not every adolescent with PCOS is obese either. And stringent criteria for adolescents should be applied, because then your approach to the problem becomes different than the approach to a lifelong approach, educating them, keeping track of them, and making sure that they don't run into becomes a responsibility as well. And we do a lot of other things usually in the laboratory. How many are actually diagnosed PCO? Many things that we do are like FSH, LH, E2, FSH, LH ratios, TSH, T4, protein, are really not to diagnose PCOS, but to rule out other causes of oligomenorrhea, where you're sure that you've ruled out in something else happening. At risk of PCOS, kids severe diagnosis. Great caution should be taken for diagnosing PCOS in adolescent girls with clinical features of androgen excess and bicultural hyperandrogenism if oligomenorrhea has not persisted for more than 2 days. This can happen very easily for you. You can see a child, she can have hirsutism, she can have irregular cycles, but has not persisted for a long period of time. She's just a year or two after menarche. What then do? You stop diagnosing PCOS because that's what the definition says, or you go ahead and call it PCOS. There is actually a diagnosis called at risk of PCOS. So her diagnosis at that time can be at risk of PCOS, and we have to continue monitoring her until we are sure about diagnosis at a later time in life. So to avoid misdiagnosis, changes, defer diagnosis regularly. And it is traumatic to a child and her family to be labeled as PCOS, because they do go back to Google these days. They do look at a lot of things. So that every possible thing to endometrial carcinoma, infertility and basis, and their interpretation is definitely different from our interpretation, and it can give rise to a lot of psychological trauma. We have to be very, very prudent before we pronounce an adolescent as a PCOS who needs lifelong monitoring. So is that enough workup that we do for a diagnosis, or should we bring something in the 3 factors that we talked about? Should there be anything more? You have to screen for insulin resistance, because that's how you have to put your effort into modifying it. Acanthosis, total obesity, and GTT being abnormal, passing insulin, glucose are all things to get done. Complex ones need not necessarily be done, but I think we have to be aware of the clinical findings, and GTT will be much more than enough for you to make diagnosis of it. And other things can happen also in the child: sleep disorders, metabolic syndrome, non-alcoholic fatty liver, psychological disorders, all of these are possible. And these children that we label as PCOS, adolescents with normal glucose tolerance, we should still be screened at least once every 2 years. And more frequently, additional risk factors are identified. Adolescents who already have an impaired glucose tolerance should be screened annually for development of type 2 diabetes, because this again should be prevented rather than allowed to happen. So metabolic syndrome, occurrence of metabolic syndrome in PCOS, about 2.2% of adolescents at PCOS do have metabolic syndrome, and 3 times more incidence than what is expected for age group, BMI, ethnicity, and it's 3 out of those findings we have to have before we calling them metabolic syndrome. And associated problems that you may not think of as being secondary to PCOS can be secondary to PCOS. We come with obstructive sleep apnea, which can give rise to a lot of potential problems: daytime sleepiness, a child which is not waking up refreshed from sleep, snoring during sleeping, potential for fatigue to contribute to mood disorder. This is there. Psychological issues also can be there at this stage. Naturally, with the diagnosis that remain, or even otherwise, what the androgenic features and putting on weight and the rest of things contribute to psychological issues are not common also. Non-alcoholic fatty liver also should be looked at and ruled out. And occasionally, if it's demanded, you may even have to diagnose it further. And then when you got your diagnosis made, you convince the family that it's something that needs ongoing monitoring. A lot of psychological comes in. This is where PCOS clinics come into play, where you have to work them up and make sure. A desire for immediate improvement of present symptoms is often the focus of patients and families. They come to you with a problem and they want a solution for that, and that's natural. So that is the focus of both the patient and the family. Menstrual dysfunction and hyperandrogenism are the particularly distressing problems for both. So it's amenorrhea is which not coming at all, secondary or primary amenorrhea, or sometimes it's excessively bleeding, which is stopped for a long period of time, with the second endometrium as well. So these ones, without saying, need to be addressed. But then we also have to get worried that the factors associated with the lack of metabolic risk may not be their concern, but making a definite diagnosis and counseling them on this should be our concern. So managing symptoms, first of all, first line is managing those presenting symptoms that we talked about. So when should the pharmacological therapy start? Do we say, okay, you wait and I have to prove hyperandrogenism, I have to prove all of those matters and pull out all of those things, unless your clinical examination actually demands multiple investigations to other factors. The treatment can precede a firm diagnosis of PCOS. However, the PCOS diagnosis should proceed and documentation of all three factors should be done before we call them PCOS. And the first line treatment, of course, is combined oral contraceptives, the management of AUB. Combined oral contraceptives, which contain estrogen and progesterone, first line treatment for PCOS with abnormal bleeding and or pituitary signs of androgen excess. How does it work? How do these oral contraceptives work? They work in several different ways. They work by suppressing the gonadotropins. We talked about the gonadotropins being abnormal to start with in PCOS, FSH, then being abnormal, ovarian androgen being abnormal. So for the entire cascade of things, the gonadotropins is helpful, and it thereby decreases the ovarian androgen production. And the issue in this COC increases serum hormone binding globulin, which comes from the liver, binds androgens, reduces free androgen levels, blocks androgen action on hair follicles. It's slight decrease in DHEAS as well. So just one component inhibits endometrial proliferation, hyperplasia, and risk of endometrial carcinoma. So the estrogens are useful, response are also useful, and it works in several different areas, achieving finally the effect that you want to achieve. And how do you choose your combined oral contraceptive? What type of the, there are any number in the market, so many different types, so different occasions. How do you choose the right in a PCOS? We tend to choose the lowest possible, usually in a young woman, a young adolescent. And generally, the advice that we give is that the younger the patient is, the lower the dosage should be, and it should be stick to the lowest possible dosage and 20 micrograms. Right there, it's micrograms. Within estradiol, there are others in there. So 20 micrograms is enough, and that is the dosage we should be starting. But however, I should emphasize that in the context of PCOS, it's 30 to 12 micrograms of estradiol is the suggested dosage, because what you're treating is an AUD, and you have to share that endometrium completely. And 20 micrograms is much more incidence of breakthrough bleeding, and that amount of breakthrough bleeding, and already with already AUP, finds it very, very difficult to cope with. And also, the 20 micrograms may not be enough to promote normal performance, which is still in a young woman. So actually in PCOS adolescent, a slightly higher dosage of ethinyl estradiol is suggested. Progesterone, the second component of obesity, how do you choose that? You'll have to choose the less androgenic progesterone. The preferred one now is actually drospirenone, which is an analog of spironolactone. The reason is because it's got anti-androgenic potential as well as an anti-mineral potential. Anti-mineral potential also is useful because they don't gain weight and weight loss effects become better with it. There is no salt retention, water retention, natriuretic, and it, but however, less androgenic do carry a slightly increased risk of thromboembolism, but in actual numbers, it's still extremely small. So I think we'll have to use the right progesterone, the right progesterone containing CUCs to be useful. Desogestrel is similar in gravity, and it's also a less androgenic progesterone. But however, progesterone is not a testosterone and not still that much more androgenic, and it's probably better not to choose CFCs containing those type of progesterones, not progesterones generally, not directly progesterones in the COC that you're using in a situation of PCOS. And also, what we have to think about is the side effect of COC. We have decided that it's okay to start at the beginning when the problem is big. It's okay to give them COCs in an adolescent child, acceptable, and has potentially a lot of beneficial effects. Does it have side effects? It does have considerable lot of metabolic side effects, increased venous thromboembolism, increased thrombotic stroke, and MI as well, salt and water retention, impedes weight loss, and perimenoptical girls with a short stature may have a risk of growth inhibition too if you start too early. So generally we don't start before the age of 16 and without that. And no increase, but however, post-lam is something a lot of people get worried about. Incidents of parents get worried about giving them pharmaceutical post-amenorrhea and the increasing incidence of infertility later is something that they worry about. We can confidently tell them that that's not a risk, okay? But the risks which are minimal, but they will be. However, the benefits of oral contraceptives in terms of getting their benefit effects for suppressing androgen levels and making their cycles better, they far outweigh the potential risks that they have at that period in time. So the benefits we think outweigh the risks, but then how long do you give? How long is long enough? How long do you keep them on that? This is also because the optimal duration of treatment is really not determined, but however, the commonest recommendation that you find in the literature is that we should continue treatment until the patient is gynecologically mature, which is 5 years post-menopausal, or has lost a substantial amount of excess weight and metabolically becomes normal. So if you have a considerably obese child, and that may be one of the triggering factors making her metabolism worse, and if she manages to go on the right diet and exercises, loses weight on her own, it may be worth a try stopping it earlier and trying to see whether her cycles become normal earlier. Okay, so we do start it fairly early, being conscious of the fact that they do have side effects in the very long term. You have to convince the parents that it might be better for her to stay on the right track, but then keep checking her more frequently. And ideally, if you can carry it to 5 years, a lot of the problems could be, especially hyperandrogenism, could have been helped much better. Do you have to use COCs? Is there any other way of managing these children? And progesterones can be used for abnormal infertility. But however, progesterones are chosen only when COCs cannot be used or will not be used by the family or the child. It can be used cyclically in every 6 weeks regimen. You don't even have to bring them out every month and use it in such a way that the child every every 6 weeks. And micronized could do NPA is one of the commonest ones that gets used. All of them are fine. And but what we are achieving with this is correcting menstrual irregularity. So the AUV part of it can be corrected, but not the hyperandrogenic part of it. There are two parts of it. So this does not address the metabolic part of it, this does not address anything other than correcting the cycle. So if the cycles are the only problem that the child comes to you with, that can be fairly easily accomplished using Mirudhubashini, especially if they are wary of using COCs. And is there an all? Is there? And but however, it does not reduce the androgen levels. There is no reduction in hirsutism. So if hirsutism is a major problem, there's no point in putting them on progesterones. And it doesn't correct the hyperandrogenism. It doesn't correct a lot of other things like mood symptoms, bloating, and all that. So managing hyperandrogenism, more than 50% of PCOS adolescents have hirsutism. Local measures are first line: threading, shaving, lasers, photoepilation, topical creams. Hormonal therapy is indicated if the response to the cosmetic and dermatological procedures is inadequate. And the goal of hormonal therapy is to decrease the effect of excess androgens, cutting down on the androgen levels. It reduces androgen production and it reduces serum-free androgen by increasing the level of binding by SHBG. So I think two different ways it does. The COCs do help. So that's probably the most effective way of dealing with hyperandrogenism in any way of sort that you're faced with is using COCs. But as we've already said, choosing the right progesterone is crucial. Drospirenone, we talked about how it has a favorable metabolic effect, and there are readily available preparations with drospirenone in there. One other thing is the synproteron acetate. Ideally, this was considered as the ideal anti-androgenic progesterone in an OCP earlier. But however, world over, most people have backed off from synproteron acetate because of the fact that the TVT and the incidence of traumatic episodes are far higher than drospirenone and all other progesterones. So I think most people have almost using synproteron acetate as a single agent as a part of OCP in treating these individuals for a longer period of time. So this is anti-androgen therapy. Sometimes they may need to step up the anti-androgen therapy if there is an insufficient response to COC and the physical measures. The anti-androgens can then act by inhibiting the androgen-induced transformation of LSA into terminal hairs. And because they have longer growth cycles, the hair has longer growth cycles. This needs to be used when it's started. It usually needs to be used for a longer time before any effect can be appreciated, maybe even as long as a year or so. And it should be prescribed with the COC preferred. And it has only a moderate effect on the other problems. So out of all those things, the one that gets used more often if really the necessity crops up is spironolactone in this situation in PCOS. So the management of PCOS does not stop though with managing irregular periods and or hyperhirsutism. And we need additional medications. OCP is most effective plus least expensive therapy for AUD and hyperandrogenism. But however, there's a low compliance rate owing to side effects such as retention, weight gain, and headache. An unfavorable effect on lipids and glucose metabolism, superadded cardiovascular morbidity is what we are worried about, giving them for a long period of time. So the long-term use has several practical problems as far as the patient is concerned and as far as we are concerned. In that way, metformin often needs to be used as an adjunct to lifestyle modification and symptom-based treatment. Dyslipidemia, insulin resistance should be definitely considered as an indication for metformin in the situation of adolescent PCOS. Favorable effect of glucose and lipid metabolism prevents type 2 DM and cardiovascular morbidity, helps in weight reduction, and combined with OCP, the effect on the lipid profile and BMI balances the negative effect on OCP and these parameters. Myoinositol can be used as an alternative, decreases serum testosterone, restores normal ovulatory function in PCOS women. Now there are enough literature evidence to say that. And it can also be again used along in combination with OCPs. Anti-androgenic side effects are enhanced, and it does have a beneficial effect on the metabolic profile. So combination of this also can be used. So which ones do we choose? So how do we go about treating these young women? Acute symptoms are treated with oral contraceptives and may be treated only with oral contraceptives. But maintenance doses to prevent problems beyond a certain period of time. We have there are benefits in adding adenomyoins to our metformin and symptoms control. Each has its benefits and problems. Improved cycle regularity, environment control of insulinemia, hyperandrogenemia is there. Metformin is less expensive, time tested for long-term use, more GI side effects maybe and maybe less compliance. Whereas myoaldosterone is more expensive, but user friendly. So you can depend on what your needs are and the patient's needs are. You can choose the right one. Behavioral strategies, I'm not going to go into a lot of details. Goal setting, self-monitoring, stimulus control, problem solving, a lot of complex things. So you need dedicated PCOS clinics that can provide this beyond the acute management that you have already provided. And or you should make this available for the patients because it's very difficult for you in a busy clinic to provide all of these things. And non-pharmacological, all this is taken for granted. I think non-pharmacological for all patients would be healthy lifestyle, reduced carbohydrate intake, exercise, and reduction of hepatovisceral fat. Diet, there is any number of variations, but in an energy deficit as well as protein-rich diet is probably works much better in these women than low-protein diets. Exercise at least 60 minutes of moderate vigorous intensity physical activity, including those that strengthen muscle and bone mass at least 3 times weekly. Activity should be performed at least in 10-minute bouts or around 1,000 steps, aiming to achieve at least 30 minutes daily on most days, a minimum of 15 minutes per week of moderate intensity or 150 minutes per week of vigorous intensity is needed. It can be structured, and self-monitoring, including fitness tracking devices or technologies, could support and promote these kind of activities. Regular monitoring is absolutely essential for us to do that for weight change, for excess weight, and for monitoring their metabolic changes. It should at least be done at a minimum if they are on medication, minimum of 6 months is necessary. And the frequency should be planned and agreed upon the presenting problems. Our family evaluation also should become part of it. Family needs to be sensitized that PCOS is not an easy to treat disorder. Long-term management is needed. Siblings need to be evaluated. Parents need to be screened for type 2 DM. Asymptomatic parents could have DM at the time of diagnosis in their daughters. So I think this also becomes part of our responsibility to suggest this to be done. Surgical management is something that you never think of in an adolescent PCOS. Iatrogenic PCOS in young women, we are seeing them more often. We change the number of ports, number of women, but not in adolescents. Despite reproductive organ is not the answer for a PCOS, especially in an adolescent age group. And so basically summing all this up, PCOS itself is normal disease, brain disease. It should really be called reproductive metabolic syndrome, which is the name proposed right now. And the diagnosis, we have to be very, very clear in our mind that diagnosis, especially in an adolescent, is not an ultrasound diagnosis. Also, when it comes to the patient, it cannot be based on any one single criteria. And strict criteria of all three problems need to be applied in diagnosis, definitely in adolescents. Biochemical evaluation needs to be done also before PCOS for a lifetime. Early treatment is crucial to prevent long-term complications, most particularly infertility-related and cardiovascular disease. Much later, metabolic screening should be part of your work and should be done periodically. So polycystic ovary syndrome generally itself, at the end of the day, it's a syndrome. It's not a disease. Let's call it. Let's not try to cure it. We have no means of curing it. Please follow research methods. And I hope that has given you some information. And thank you very much for spending this time with me. Thank you.
We can go for the question answer session.
Yeah. second bad, Dr. Govind, what should be the first line of treatment? We like to talk about it. First line of treatment can be the OCD, especially amenorrhea or menstrual problems are very severe, or the hirsutism or the androgenism is very severe. The first line is COCs, combined oral contraceptives. Um, and then if you need to, you can add on other things depending on what the presenting problem is. You cannot put them on diet alone and think that that's going to solve a problem in a 16-year-old with a major problem. Dr. Namalkar, can you emphasize some pharmacological treatment? The primary pharmacological treatment is actually still combined oral contraceptives. In terms of decreasing the insulin, hyperinsulinism and insulin sensitization, there are many things which are novel things also available, but they're not proven as yet. You know, there are the newer agents that being used as anti-diabetic agents. Some of them have been suggested for PCOD management, but I do not want to sort of endorse anything like that at this point in time because there is not enough literature. Other than the normal one, some modern, there is no such thing as a modern diagnostic criteria. The only thing that we have to be clear is accepted worldwide diagnostic criteria. Rotterdam, I agree, is a few decades old, but then what we have to understand in the context of adolescence is the same Rotterdam cannot be applied to adolescents. It has to be all three of them and modified, all three of them in a modified way, like we have outlined. Androgens and estrogen metabolism, that's what we talked about. They produce too much of androgens. That's the thing. It can be mostly, or if not all, ovarian androgens, secondary to a higher stimulation or a different stimulation from the pituitary. And the pituitary now we know is managed by even a higher authority from hypothalamus, which is the kiss peptides that we talked about. So its pathology starts there, and that is the pathophysiology and etiology. Hyperinsulinemia in the etiology of polycystic ovary syndrome, no, it's an effect of polycystic ovary syndrome. If you look at it, it's hyperinsulinemia, hyperandrogenemia, and then the clinical manifestations. But where the pathology starts is in the hypothalamus, pituitary, and the pituitary hormones is where it starts. How are ovaries characterized in syndrome? The definition is density in volume and over 12 antral follicle count in the early part of the menstrual cycle. That has to be done by ultrasound. But however, in an adolescent context, the number of follicles quite so much. Number of follicles have been increased over a period of time to 12 to almost 25 now. Which manifestations of hyperandrogenism suggest polyovarian syndrome? Two main things: the cutaneous androgenism and virilization is not. Virilization is different from so when we try to we had problem and time. So you have these young and PCOS, this is the big question. PCOS on menstrual disturbance and he is very so I think progesterone containing COCs are the ideal things for them initially. That would be the way to go. What is the role of measurement of SHBG? To 5 from continue from in my install. We do you may stop. But then you have right especially amount of ether they back to normal to decide how long we are able to get really depends on how severe resistant to really are there before you make it. Very specific, deviate taking most of these beyond money should be but
Ma'am, you can give a short takeaway message till then.
the short takeaway message is that adolescent part of PCOS is probably the most important part because it lays the ground for the problems that this woman is going to face much, much later. And we see how we struggle with severe PCOS when we're 20, 15 much later. And even much later, we are not, it's not impossible for us. We do see very young adults, PCOS, severe PCOS, developing endometrial carcinoma, breast problems. So I think it is a diagnosis that you have to, we are obligated to make that diagnosis when a child comes in with all of these problems at a much earlier age group, in the adolescent age group, and provide them with the right guidance, maybe sometimes even for the rest of their life.
Yes, ma'am, that's all with the questions.
Okay. We finished with the time as well, right?
Yeah, ma'am.